Good afternoon, esteemed guests, presenters, and colleagues. Welcome to Parallel Session 2.1 Dynamics of Population and Sexual and Reproductive Health. Our esteemed presenters will delve into key topics such as population aging and the influence of socio-economic factors on reproductive health. We encourage active participation and discussion as your insights and experiences are invaluable to enriching our understanding of these critical issues. So, welcome and let's get started. I'm pleased to introduce our session co-chairs for Parallel Session 2.1. First, we have Ms. Manuel Hurwitz, the Director of Development and Impact at the International Planned Parenthood Federation. In her role, she oversees global sexual and reproductive health programs, providing crucial technical guidance and managing supply chains to support humanitarian efforts and evidence generation for IPPF member associations. I'm also excited to introduce Dr. E.L. Sunetra J. Pereira, the Professor, Chair of Demography Department at the University of Colombo in Sri Lanka. She currently serves as the President of the Population Association of Sri Lanka. Now I'll hand over the session to our co-chairs, Ms. Manuel Hurwitz and Dr. Sunetra Pereira. Thank you both for leading this important discussion, and the floor is yours.
Very good afternoon to everyone and welcome to the session 2.1. As discussed with Ms. Manuel Havitz, so we are so fortunate to have her as one of co-chairs of this session. Our session theme, as explained by Ms. Harsha, so the dynamics of population and sexual and reproductive health. We have 4 presentations today. And each presenter will be given 12 minutes. So, yeah, all presenters need to stick with the time. And after 10 minutes, maybe we will indicate the time. So, and then 12 minutes time. Suppose you are sharing the presentation between maybe co-authors, please be, stick with the time. And let me hand over this, to introduce our presenters to Ms. Manuel. Thank you.
Thank you very much, Professor Sunetra. It looks like we might have more panelists than we have an audience, but that's okay. If we can also ask people to come towards the front as much as possible, so that we can be closer together. And then, as we've indicated, we'll be very, very strict with time. That means that when we say it's out, it's out. So please, apologies in advance. This is not out of being rude, it's because we just want to make sure everyone has a chance to speak, and we don't want the last panelists to be rushed. And we want to have time as well for the audience to ask questions. So we will start without further ado with our first presenter, Maria Said. Maria Said is a member of the Society for Health Education, so that's the IPPF member association in the Maldives. And she served as vice chairperson from November 2023 to September 2024. Maria has over 32 years of experience as a medical laboratory technologist, and she formerly led the Thalassemia and Diagnostic Laboratory Services. So welcome, Maria. She will be talking to us about addressing reproductive health challenges posed by thalassemia in the Maldives, and she will specifically focus on examples from She Maldives program.
Thank you very much for the introduction. Assalamu alaikum and a very good afternoon to all of you. Well, my topic is addressing reproductive health challenges imposed by thalassemia in the Maldives. Insights from She's outreach program. And the presentation is co-authored by Dr. Naila Ibrahim Didi, also known as Dr. Naila Firdaus, and she is the co-founder of Society for Health Education, and she is the first gynecologist of the country as well. And she has contributed in the field of reproductive health in a very large, for a very long time. The objectives of my presentation is to evaluate the impact of SHE's outreach program on addressing reproductive health challenges associated with thalassemia in the Maldives. Thalassemia is one of the huge public health concerns of the Maldives, and I think the beta thalassemia carrier percentage is the highest is in the Maldives from globally. So from this, we have done assessing the prevalence of beta globin variants, identifying high risk islands, evaluating the effectiveness and or outcome of genetic counseling in facilitating reproductive decision making. The methodology was secondary data from SHE thalassemia prevention initiatives. One of the focus areas of SHE Maldives is thalassemia. It is a very high public health concern in the Maldives, and SHE has a thalassemia screening lab which also can do genetic analysis. And we have had a national thalassemia prevention program since 1996, and we have the data we have used for this has been more than 100,000 people were tested. So it is 1/3 of the population. So from the screening and the DNA studies and genetic mapping, what I mean by genetic mapping is we have different variations of thalassemia carriers in different islands. We have noticed that there are pockets of different variants, which is very prevalent in some areas of the country. The results of the study showed that high prevalence of beta thalassemia globin variants and prevalence of anemia in the carrier population of thalassemia and the hemoglobin variants. So the result is 1 in every 5 person is a carrier for beta thalassemia. So we have included people from above 12 years of age in this screening program. That is because we have a legal age for marriage is 18. So before the marriage, it is very important to know if you are a thalassemia carrier. That is why we have selected the age group starting from 12 years. So 1 in every 30 marriages are between 2 carriers, and 1 in 120 live births is a thalassemia major. This is, of course, when we did not have any genetic counseling and premarital counseling for this issue. So we have found that 18.2% of the population carries a variant of a hemoglobinopathy. And specifically, if you look at only beta thalassemia, 16.3% of the population carries the gene. And beta thalassemia is a recessive gene inheritance disorder. So from the results, we have understood the critical need for preconception genetic counseling, because the variants that we find in our population has risks of carrying a child who can be transfusion dependent for the whole life. So pre-genetic counseling is very much, we have to design it for the pockets of population where each type of variants are prevalent. And premarital thalassemia screening mandatory we have made it mandatory before registration of marriages. Because of the outcome of SHE thalassemia screening program, we were able to advocate for premarital genetic counseling and also premarital testing for thalassemia. And prenatal diagnosis was also introduced because of the thalassemia situation in the country. But it is very sad that still we cannot get it done in the country. We have to go abroad for any prenatal diagnosis. But we have now had affiliations with India, some of the hospitals in India, and we are able to send people just in time for them to do the test. And also, because of the thalassemia situation, the SHE program influenced establishment of many transfusion facilities and created high demand for thalassemia voluntary testing. The significant reproductive and psychological health challenges faced by carrier couples in the Maldives is known from this. And we have taken this screening program to the schools. We started screening children from schools of the age group above 12 years, and we have received some very interesting feedbacks from the screening programs. Some of the children at the age of 14, 15, they are in relationships. And since they don't know their career status, they were very shocked that they can be carrying the gene and without knowing they have taken a boyfriend or a girlfriend. And if they are at risk of getting a transfusion dependent child. So this was a major concern raised by the population, the public, and this is the challenge that we have been facing, and this is one issue we had to address. So the nationwide screening program has made a lot of changes in the policies, like mandatory testing for thalassemia before marriage, and also voluntary screening has become a necessary thing. And now we have a Thalassemia Act passed by the government, and it is mandatory for each parent to get their children tested before the marriageable age of 18. It is a very big challenge for screening to be conducted across the country, because we have isolated islands and each community is very, very closed, but it has been changing since people have started traveling to other islands for purposes of education or health or other needs. So now there are intermarriages between communities, but in the earlier days, it is a very, very condensed genetic pooling. That is one reason why we have pockets of different genetic variants of hemoglobins in different places. So we had to design our counseling package specific to the island need. We have certain islands with very high sickle cell carriers percentages. In some areas, we find hemoglobin D, and in some areas, we have hemoglobin E, other than beta and alpha thalassemia. So we had to design our counseling packages according to the need of each island. And the risk of each island community is also being made aware for them when we give the counseling. Actually, the thalassemia challenges that were faced, the sexual and reproductive challenges that were faced by the thalassemia community made it mandatory to make the termination of pregnancy was legalized because of this situation. And it is very difficult to have a transfusion center in every island, but we find that each island has thalassemia carriers. There's no island which is not having any carriers when we did the screening. So it is a very difficult situation for the families to travel to another island to get a transfusion. But this has been improved by establishing about 108 transfusion centers across the country. But still, there are some children who needs to travel for a transfusion. So we have actually expanded, and also some of the choices that we give for couples who are carriers, some of them, they are in love and they cannot separate. So they decide to get married. But what are the options for these couples? The options that they can have is they can decide to not have children, or they can decide to have children and do a prenatal diagnosis and a termination of pregnancy in case of a thalassemia major. So we have long-term outcomes for couples, and we have to, intervention strategies has to be implemented more. Development of island-specific counseling packages, consolidation of prenatal diagnosis services, development of simple monitoring and evaluation, infrastructure and capacity development, future application of genetic and genomic technology in the thalassemia and hemoglobinopathies. Actually, I would like to add that now these are my references. The thalassemic population is becoming adults. So they also fall in love and start families. But for them to have a child, they have to be thinking of their sexual and reproductive needs from the time of their puberty. Sometimes delayed puberty because of growth retardation in thalassemics when they're not properly treated. So all these has to be addressed. My topic is actually to help them have families, not contraceptives or other things, but to make their body ready for families to have children, and This is a very different topic from most of the topics that we discuss here, but we now face these challenges. I have listened to one of the thalassemia majors who is an adult, and now she has a beautiful baby, but she had a long journey to conceive a child. So these challenges is not in the country. They have to go abroad and have this baby because they had to do IVF and all that. Thank you very much for listening, and this is my story.
Thank you very much, Dr. Said. A very, very good and concise presentation. And it's really great to see the commitment and the action of the government in their national screening program, and how this program and this commitment to eradicating thalassemia is also feeding into a lot of sexual reproductive health, including contraception, including, as we were hearing earlier, abortion care, but also because it is sexual reproductive health to allow and to facilitate people to have healthy children. Fertility care, as we know, is also an integral part of sexual reproductive health. So from thalassemia to menopause, we'll go to our next speaker, who is Dr. Asanka, who will present on the study of the results of an online study on knowledge regarding menopause. Dr. Asanka graduated in medicine from the University of Peradeniya in Sri Lanka and completed her medical internship there. She holds a diploma in family medicine and is an international member of the Royal College of General Practitioners. So, Dr. Asanka, please come and join us.
Good afternoon, everyone. And I'm here to present my research paper. It's about knowledge on menopause among women. It was an online study. Introduction to my study. According to the WHO, which is World Health Organization, menopause is defined as the permanent cessation of menstrual cycles for a duration of 12 consecutive months. Women's physical, emotional and mental health undergo dramatic changes throughout the perimenopausal time as well as the menopausal time. Perimenopause is a time where you have the transition. And also I would like to point out the first menopause-related National Institute for Health and Care Excellence guidelines was released in 2015. That demonstrates the increasing recognition of its significance in healthcare. And also, in addition to that, menopause education was made mandatory in schools in 2019 as a component of relationships and sex education. Actually, there were very few studies that I could find in the internet, and there were some studies that I wanted to point it out. Research on younger women's education and understanding of menopause is quite limited, and a study conducted in Egypt revealed women of reproductive age had very little knowledge about menopause. And also study which is conducted in Jordan that has given women were familiar with the concept of menopause. They had minimal awareness of its consequences. Objectives of my study is to assess the knowledge on menopause among women aged under 40 years living in Colombo and to determine from where they gathered the information on menopause. This is brief description of methodology used. I have used a Google questionnaire. A survey was created asking women under 40 about their knowledge of their opinions regarding the menopause. This study was conducted from January 2023 to December 2023. The questionnaire was a pre-tested questionnaire. Actually, the original study was conducted in China, and since it was pre-tested in China, I didn't pre-test it here. And a free text question with answers was analyzed using Excel. A randomly selected sample of 225 women were selected, and the demographics of the female respondents were analyzed using Excel. And I have analyzed the level of knowledge regarding the menopause, educational experiences, learning about the menopause, and how knowledgeable do women feel about the menopause, how they had found information about the menopause, and the best places to teach people about the menopause, and the importance of teaching men about menopause. These are my results, as actually this shows the age distribution. There were in my study, 15% were less than under 20, and it was 65% was in between 21 to 30, and 20% was in between 31 to 40. And analysis of the relationship status showed that it's 60 plus were married women, and more than 30 plus was in a relationship, and 120 plus were single ladies. And according to the parity distribution, it shows that 158 were with no children, and 35 were with one child, 21 were with two children, and till around 11 had was a mother of three children. The analysis of highest educational qualification showed that the 83 were with secondary school, and 123 were undergraduates, and 19 were postgraduate ladies. And the first graph shows the women asked how informed they feel about the menopause. This showed that the less than 20 were not sure whether they were informed or not. And almost in all three categories, for an example, less than 20, 21 to 30, and 31 to 40 was not sure whether they were informed about this menopausal transition. And in the second graph shows women were asked how menopause was covered in their school lessons. According to the analysis shows that less than 20 says almost all three first two categories, that is less than 20 and 21 to 30, says that it was not covered in their school lessons. And according to the analysis, between 31 to 40 category says that the basic things were covered in their school lessons. And in the third graph shows women were asked if they had been taught about menopause at school, and according to the analysis, all three categories were not sure whether it has been taught or not. And in the fourth graph, women were asked how they had gathered information on menopause. That shows that less than 20 was mostly got the knowledge about menopause from the newspapers. And from the analysis, it shows that the social media has contributed a lot in 21 to 30 category. And when I considered the 31 to 40 ladies, it was mostly from friends. And from there were some parts of the questionnaire which was asking about the symptoms of menopause and the signs and symptoms of menopause. And according to the age, the analysis showed that women get older, they tend to perceive themselves as having more knowledge about menopause. Younger women who is under 20 are more likely to have learned about menopause in school, while it was far less likely to be covered in the education of older women, particularly those over 40. In conclusion, the majority of women under 40 know very little or nothing about the menopause. The analysis showed that everyone should be taught about menopause in schools, and this will help to lessen male ignorance. In schools, workplace, those are the main two places which I encounter to educate regarding menopause. Recommendations through my study. First is the effective menopause education in schools requires that it to be comprehensive and given to every student. Local support groups to be introduced to help specifically for women going through menopause, where experiences can be shared and support can be found. Introduction of lifestyle changes, diet and exercise, and also exploring the options such as acupuncture, yoga, or herbal remedies may help to undergo menopause. Educate the women explaining the benefits and risks of HRT to make informed decisions about managing symptoms. Introduction of mindfulness and relaxation exercises can help alleviate menopause symptoms, and also counseling therapy if menopause symptoms are impacting mental health. And these are my references. Thank you.
Thank you very much, Dr. Asanka, for keeping to time and for a very, very interesting study on a very largely under-researched and under-recognized topic of sexual and reproductive health, one that even WHO does not have any guidance on. So that is something that hopefully they will be working on soon. We do at IPPF have a medical statement from our International Medical Advisory Panel, which is on our website on menopause. And I think a lot of the recommendations you have highlighted here are highlighted there as well, including the need for supportive policies in the workplace as well. I think in addition to everything else that you have mentioned. So thank you again. We will now go to our next panelist. I'm very pleased to welcome Dr. Saraswati Jangam. Dr. Jangan is a practicing gynecologist at FPA India, dedicated to addressing the sexual and reproductive health and rights of vulnerable and marginalized populations. She prioritizes client comfort, education about their health situations, and comprehensive treatment planning. And Dr. Jangam will present on sexual and reproductive health challenges on population aging and the unique sexual and reproductive health needs of aging population, menopause, again, and the elderly. Welcome.
My topic says unique unmet needs of aging populations, menopause and elderly. Actually, as menopause is already something which is not discussed very frequently or very talked openly, same way are the unmet needs of aging populations. They are not talked openly or discussed openly with the population. Startingly, we didn't have that we should do any search of this, but as the clients who come to the clinic, they get and we noticed that fewer things they couldn't speak directly, but they were like unwritten words of the lines. Then we started to make a little study on that topic, and this is how we could make few things. With me are the other two co-authors here. Sexual and reproductive healthcare encompasses a broad range of services for a safe and satisfying sexual life as they enhance individuals' well-being. So this was the point which we could identify that well-being, we could, at the starting, we could cure their symptoms, but the well-being was not seen after even giving the symptomatic treatment. Then slowly we dwelled into their personal lives, their sexual lives, and slowly we could gather the information regarding that. Meeting the unmet unique needs of SRHR can help us achieve complete health coverage of the aging population. Aging is one of the most significant global trends of the 21st century, which presents new and complex challenges for health symptoms as important implications for sexual and reproductive health for older people. Like here, older people, they have many symptoms. They themselves are not able to tell or specify what is bothering them. Sometimes they say one symptom, sometimes they say other symptoms, sometimes they feel neglected, they are not cared, but sometimes they are stressed. So we need to address all that small problems where we could justify their total well-being. Okay. Yeah. Sustainable Development Goal 3 suggests that states should ensure healthy lives and promote well-being for all at all ages. So we being in the present reproductive and generative for the growth, the elderly population should also be cared and not to be neglected. So we should not miss caring them also in all the aspects actually. FPA India Pune branch, established in 1977, provides a range of SRH services through static clinic, satellite clinic, and service sessions in the community. As this is a part of my daily work, that is the reason I could get into all these things. SRH needs of aging populations, including those undergoing menopause and the elderly, are often overlooked, especially after attaining desired family size. After children go out of country, husband is still working, she is inside the home doing all the course. If anything, any work is there, mama is there or grandmother is there, she will take care of. So they just by default they consider that female lady and they go on with their work. So my objective was to describe the unmet sexual reproductive health needs of aging populations between 45 to 60 years, including those undergoing menopause and the elderly. Like here, I would like to mention one female lady was there. Her husband's sugar level were very high, so she was even scared to get near him, so that any work or any stress should not cause him more ill health. So she was like, okay, I'm just taking care of him. But she missed like sitting beside him, cuddling him, and all. But when we slowly talked with her, we get into, then she told, no, I am scared because I love him more. I don't want him to get into more trouble. So the methodology we followed was this was the routine service statistics gathered at the FPA India Pune Static Clinic during January to December 2023, and this was used for the study. FPI Static Clinic provides clinical and non-clinical SRS services to over 7,000 clients in a year. The study included 205 women aged 45 to 60 years of age who visited Pune Clinic for STI, RTI services and gynecological related services. So the first presenting symptoms were for STI, RTI services or gynecological, like white discharge, itching and all. For that, they used to visit us first. The selection of the clients was based on their complaints, history and duration, since how long they have been suffering. Like few directly they used to come, ma'am, I have visited 3-4 doctors, I have taken all the consultants, I have taken the treatment, I have even spent 6,000 rupees or 7,000 rupees, but I am not convinced with the treatment, or I am not feeling the relief. So slowly we could find out that even after using so many of antibiotics and treatments, antifungals, why she is not getting the relief. Maybe the causes are still more which are not unmet or unattended. The selection, since long, how long they have been suffering. Here, dwelling into the personal history to know her unmet needs and her emotional status was also considered. These clients were educated about their conditions, discussed different options, and encouraged them to select their best suit for their personality. Before doing that, we took their consent for follow-ups and visits for checkups. Like I would like to mention one widow. After her husband's death, it was her son. He was not allowing her to go out, or if she wanted to go anywhere, she needed his permission, and she has to tell him when she will go out and when she will come back. So every restriction of her, he used to tell, no, I am looking for your safety, I want you to be careful. But in that sense he was giving all the restrictions of her freedom, and that slowly caused her emotional stress, and she had continuous of white discharge of 6 months she was facing. And as we could understand her emotional status, then we spoke with her, we explained her, we counseled her, and slowly she got the relief from the symptoms. The results we found out, the respondents of for this study in the age group of 45 to 60 years had visited with the complaints of severe low back pain, pain in the lower abdomen, dysuria, dyspareunia, vaginal dryness, vaginitis, severe weakness, feeling low many times, loss of appetite, loss of interest, etc. As a first step, menstrual, obstetric, and medical history of the client, family history, personal history, upbringing, shows social exposure, educational levels, her emotional status with her unmet needs, everything was considered. So we tried to take the complete picture of her to help her. The study shows that 35% of women are affected among the sample group, and among that 20% were suffering from the stress generated symptoms. So more causative factor was the stress generated symptom for their daily lifestyle, like I have to finish this work, I have to finish that work, and the family members used to say, you please take care of this work, that slowly her anxiety towards that, and her stress that she is not able to cope up with the activities, as slowly getting on her mind, and slowly she was developing into the stress symptoms. And 40% of menopausal women were found to be neglected regarding their sexual health and well-being. Like in this factor, I would like to say, like few male have sexual dysfunctioning, but as they grow, they don't want to commit that with their wives, so they make a space or keep a distance. No, now children are grown up, or I'm not interested, like. But at that time, wife sometimes needs, that is her need, and she is neglected of that because she is not able to tell the things. The frequency, we can say, is 1 in every 6 women is affected. All their medical issues were addressed and assessed. Their gynec complaints were treated, like white discharge, etc. We could treat them first. They were educated for the use of personal lubricants for vaginal dryness, dyspareunia, and their unmet issues were discussed wherever required. The partner was also involved. Like for the widowers or who were husbands were medically ill, we taught them about the pleasures of their own personal bodies. If they were interested, we dwelled into that side also, where few female were ready to explore themselves with various different methods. Okay. The use of personal lubricants opened new options for the pleasure. When we said sometimes lubricants doesn't give the friction, or doesn't give the lower abdominal pain, doesn't give the discomfort, you may try. So few tried, and we got a very positive feedback, and they were feeling completely happy with that. As clients gained confidence in our approach, they became FPI's clinic ambassadors. As they gained the confidence, they were comfortable with their further changes in their life. They slowly in their community they explained themselves, and they made our clinic as a friendly clinic for them. Few challenges they faced for accessing services where they could not explain the problems openly, couldn't come to the hospital alone, lack of money to seek treatment, scared of to visit the hospital at first, children had no time to attend respondents' needs due to their working schedule. We addressed their issues by adopting strategies such as giving medicines for a long time, and asked her to come for follow-up as per the availability of her family members, or follow up virtually on mobile. Women in the study group belong to different backgrounds, education levels, different economic class, etc. Still, there were challenges to the accessibility of the services. 1/5 of the women experienced gynec problems, 20% due to stress that manifested into physical changes, and 40% of the menopausal women suffer due to hormonal imbalance, hot flushes, mood swings, etc., and are neglected by the husbands and family members, leading to lonely feelings and stress. My recommendations are: it is recommended to develop targeted educational programs and awareness campaigns to increase understanding of SRH issues specific to aging populations, including menopause and elderly, as this would help in reducing stigma and empower individuals to seek care and support timely. Incorporate SRH services into including regular screening and preventive measures, hormonal and non-hormonal treatment options, mental health support, and counseling into routine health care for older adults to ensure comprehensive care. These are my. Thank you.
Thank you very, very much. Another really important presentation and one that shows that when women going through the menopause does not necessarily mean the end of a sexual life, including pleasure, including needs, and also including risks such as STIs. And I think there have been many studies that have shown that in some population there is an increased risk actually of STI and HIV among older people because they actually do not think that condom is a need for them. So an interesting change of our own knowledge where we always see the needs of young people more acute in condom use, whereas actually sometimes we also need to remind older people that they need to use condom as well. And then equally so, I think you've mentioned something really interesting about the need for women still to have some of that sexual attention and that affection from their partner. And the other side is also true that men often feel they have needs that they want to see satisfied, and women may not be interested. And there is an increase of sexual and gender-based violence that's quite often as well present among older people as well. So without further ado, we'll go to a duo presentation now. So I'm very excited to welcome Vinitha and Ragini. Vinitha is is it Baoyan? Is that correct? Baoyan, queer feminist researcher with a specialization in sexual and reproductive health and rights. Her work with feminist movement spaces emphasizes abortion rights, particularly through the lenses of a queer and anti-caste narrative. And Ragini is an independent consultant specializing in sexual and reproductive health and rights with a focus on access to contraception and safe abortion. She creates knowledge products and engages in strategic communication for normative change alongside conductive qualitative and digital research. And both Ragini and Vinitha are going to be talking from the experience of India, and specifically on and I'm just going back to my notes, on the trends and tactics of anti-choice in India, an analysis through media and community monitoring.
Thank you. Good afternoon, everyone. So the topic, as mentioned, is unveiling the anti-choice agenda in India, mapping opposition groups' narratives and tactics and implications for marginalized communities. So Ragini and me, we both would be presenting, and we co-authored this with Dr. Shavik Pine, and we all are members of Common Health, which is a pan-India coalition of activists, researchers, grassroots organizations, and we work on three thematics of maternal health, reproductive rights, and safe abortion. And like to give a context, like India has law on abortion, and it from like 1971, and it is fairly like a liberal law, as we have also heard in the former plenary in the South Asia region. And but like to also understand how this law also came into accord was also there were high maternal mortality rates in India because of unsafe abortion, and doctors were getting persecuted under the law, and which is why it's not abortion seeker centric law, but actually a provider centric law, like specifically from a lens of population control. and like abortion still is highly restrictive because of a lot of like social stigma and provider biases, and it doesn't cover a lot of like abortion seekers from and its diversity. So but like like opposition in India like was not very prevalent, and there wasn't like a lot of like organized opposition like in India till 2022. And like we saw the first pro-life march in India happening, especially in the capital of India, Delhi. So what we did was like common health, what we did was try to understand, monitor like who are these key actors, and like what are the tactics and messaging that they are also propagating. um, so like we did this with the support of FOS Feminista, which is also a global feminist alliance. And the idea was to see like because of overturning of Roe v. Wade, like if it had any ripple effect in the global south countries. So so yeah, so and like to like apart from explicit opposition, like who are explicitly talking about like anti-abortion and like repealing MTP, like if whether like they were like actors within like within like departments, health departments, who also like implicitly talk about like abortion, or like if there are laws like that that sort of like harms like asserting abortion rights in India. So so we try to map it in media, policy, society, and healthcare levels, in different institutional levels. And this was conducted in September 2023 to August 2024. The media particularly tried to see like the kind of narratives tracing back to 2018, and we try to look at it from keyword searching in three languages, in social media and websites. And we particularly chose like southern and northern regions of India because we saw like a lot of activities in these regions, and also in the context like these two regions are also often excluded from the mainstream discourse. So so like the other reason that we also try to do was like like to see like whatever is in the social media, like how it also is panning out on ground, at the grassroots level. So we try to validate those like information whatever we found on media, and see like what are the different kinds of like community level or like grassroots level tactics that is being employed by explicit opposition. So the results will be shared by Ragini.
Thank you, Vinita. For the results, we tried to profile the key entities that are involved in generating this discourse and partaking in these activities. And out of those key entities, these are 8 entities, by the way, 4 were NGOs and 4 were religious institutions. And they exhibited diverse religious profiles. There were Hindu religious organizations, there were Christian, evangelical organizations, and they have different target groups, mostly very alarmingly children and women. And they also operate in several geographical areas, mostly in Mumbai, especially in the southern parts of the country. By studying the discourse that they're generating and have been generating over the years, we have sort of profiled the key narratives and emerging themes. And one of that is that there is an intersection with other anti choice ideologies. The opposition towards abortion is embedded in a larger anti-gender, anti-SRHR environment, where it's not just opposition against abortion rights or abortion access, but also they are insinuating that homosexuality is unnatural, transness is unnatural, and they're instead advocating for traditional values like sanctity of marriage, abstinence. And alarmingly, they're using disinformation to persuade people, and especially young people, to follow these. And the fetal rights focus, the narrative, the dominant narrative that it's emerging is that the life from conception argument, that life begins from conception, and hence this fetus is a human and is thus entitled to moral and legal entitlements. It has to it will come under the purview of the law to kill this human being, and is thus against the right to life and right to equality. There is, of course, scientific manipulation. If you visit any of their websites, there will be like APA 7 formatting references of research papers and references that we tried to actually find in different repositories, but alas, unfortunately, there aren't. But very alarming evidence that they have cited saying that abortion causes ovarian cancer and breast cancer and will cause a lot of psychological distress. And this is by far the most alarming and most distressing finding, is that through educational outreach and massive educational outreach, which consists of seminars, workshops, and it's even happening like every month. And there are pro-life centered courses in schools and colleges that are trying to induct a new, very proactive generation of young pro-life advocates or anti-choice advocates who are also, out on social media making reels and dancing to songs like "We Are a Pro-Life Generation." So these are some of the imagery that they have used. These are highly sensationalist images, very gory images, and you can see like the silicone fetuses that are used to insinuate or evoke feelings of emotionality. And these are some of the strategic tactics and public outreach activities that they are employing. Mostly it's crisis helplines. They have set up crisis helplines for people going through under unplanned pregnancies, and they provide, or they claim to provide, accurate information, and also set up linkages with crisis pregnancy centers that provide these people going through unplanned pregnancies with livelihood, with shelter, with medical help. But also they exclusively provide or say that adoption or parenthood is the only viable alternative to unplanned pregnancy. Of course, I have already mentioned about educational outreach through massive workshops and seminars, social media campaigns. 10th August, which is the anniversary of the Medical Termination of Pregnancy Act 1972. Regularly on 10th August, you will see these entities posting things like Black Day or abortion is murder. And of course, mass mobilization that Vinita has already touched upon, where more than 2,000 people, including gynecologists, doctors, come out on the streets in the middle, like in the capital, in different states of the country, saying that we want to repeal the MTP Act because it is unconstitutional, since it advocates for the murder of the unborn child. So here you can see like young children sitting in the shape of a cross, mourning the lives of unborn souls that have been lost. And of course, these are like pro-life exhibitions, very young children interacting with silicone fetuses. So in conclusion, it definitely undermines safe and legal abortion services. It results in increased unsafe abortions. It reinforces the stigma and shame that is already existing. Another very alarming thing is that there are different global connections. We also tried to see if there are transnational linkages, and we did see that organizations like Human Life International, Pro-Life Global are increasingly supporting with funding, with resource persons that they send to India to conduct these seminars and workshops. And they're using faith-based organizations, and it's so strong. The thing is that when they say something, it is with such urgency, with such immediacy. What we are saying, seems like there's still time, but what they are saying seems more personal, emotional, and has more power to sway. And of course, the focus on younger demography and the uses of pseudoscientific claims, and in an environment where there is already lack of information and awareness, any information that is, spread out so aggressively is more prone to be taken up. Selective presentation of information on abortion. There are moral and legal tactics where religious texts from the Bible and from the Hindu texts are used to reinforce their arguments. And of course, this has far-reaching implication for trans people and marginalized folks who already have so much barriers to access. And with this added information on the unnaturalness and how this is perpetuating a culture that is very unlike to India's, is just marginalizing them further. For recommendations, we recommend that we develop counter strategies, very proactive context-specific counter strategies that address this stigma and misinformation. And we focus this on protecting reproductive autonomy. There is a need for more cross-border collaboration. We need to sit together as RHR advocates working across the world, and civil society members. We need to sit together and think about how to counteract this, since it is clearly a transnational movement. And definitely our study was a more preliminary study. There needs to be constant monitoring and to deconstruct what this global trend, what is their agenda, and how they are, since this is very clearly well funded and they're so strong in how they operate. Yes, just that. Thank you so much.
Thank you so much, Ragini and Vinita, for this incredibly important and interesting work in a country like India, where I think in the context of abortion, at least everyone felt a little bit that this was we had gained that space. This was a battle that had been won, and it basically shows that we're never safe, and we have to be constantly vigilant, because, as you quite rightly emphasized, we are facing an increasingly well-organized and well-funded anti-rights, anti-gender opposition and movement that is impacting the world and is going beyond the country and one specific country, and definitely will now be further emboldened by the election of Trump. So it's particularly galling that we are now discussing this while he's announcing his victory. So I think that it's a reminder again of how important that work is and how together we must stand in order to fight back. So thank you for that. And then we'll go to our next and last panelist. So I'm very pleased to welcome Hasala Vimalaratne to the podium. I don't know where Hasala is. Oh, you're there. Oh, wonderful. I was looking for another woman. Sorry. A 24 and 26-year-old final year student at the Zhejiang University in China. He has a strong passion for reproductive health, and in particular is interested in the latest trends and advancement in the field of sexual reproductive health. And he will be presenting on the adaptability of China's post-one-child policy sub-fertility strategies to Sri Lanka's reproductive health care framework. So really looking forward to hearing more about that. So go ahead.
Thank you for the introduction, and good afternoon, everyone. Thank you for being here today. So the topic of my own research is assessing the adaptability of China's post-one-child policy sub-fertility strategies to Sri Lanka's own reproductive healthcare framework. So here so this is my introduction. And so here what I'm trying to explore is how Sri Lanka could adopt from China's one-child policy after its relaxation, and how it can be used to overcome the subfertility challenges that we are facing currently in Sri Lanka, and how to embody that to a Sri Lankan own framework. So let me start with the methodology here. So I approached this complex question with a comprehensive literature review that was conducted using PubMed and other databases that I've used. So here I have selected more than 100 studies, and they were systematically categorized by themes, including the subfertility trends and demographic shifts, the assisted reproductive technology clinical outcomes, the government policies on fertility treatments, and the socioeconomic barriers faced. And I would say that other than these literature reviews, I came out to these conclusions, and the data I used were also on my experience that I faced in China. So let's jump on the results. So first, here I give some recommendations and results that I found with the research that I from the research that I found from all the literature reviews. So first, we need to improve our public health services. So this includes introducing national health insurance schemes and also enhancing the infrastructure that's currently used to for these infertility treatments here. And then we can use data-driven systems and advanced technological methodologies. Like in China, they currently have a decision support system, which is used in vitro fertilization mainly. And it helps clinicians to make informed decisions and analyze large data sets, thus predicting the outcomes. Other than that, there are robust data management systems like the China's ART system or like the Assisted Reproductive Technology Information System, which is crucial for their own policy making and their practical improvements. So incorporating these to our healthcare system can also be beneficial, and it can make the lives of the clinicians easy. Other than that, they have incorporated advanced technology in sperm assessment technologies, which also enhances the accuracy and the consistency of the data sets. Then in China, they have this thing called phase development models. So in phase development models, they introduce strategies gradually to families to adjust shifting economic and social landscapes before they introduce more stricter policies. This step-by-step approach would encourage smooth adaptation and greater public support. Then medical legal policy changes are also crucial. For instance, like policies that encourage medical leave, especially for infertility treatments, can provide the time and the support the people need without added stress of their work. So other than that, I would say they have developed guidelines for posthumous assisted reproduction, which is the use of cryopreserved sperms, eggs, or embryos after the donor's death. I see this area is often neglected in Sri Lanka due to the lack of policies and the guidelines. Next, it's essential to address the social and cultural norms surrounding male infertility, especially. Because in Sri Lanka, male infertility often goes unaddressed due to cultural stigmas and misconceptions that place that the women is primarily responsible for infertility. This can lead to underdiagnosis and inadequate care. So addressing this male infertility is through targeted interventions could also improve the reproductive outcomes. Then we have leveraging family planning, education, and awareness. So in China, they have these mobile health platforms such as WeChat. In these platforms, they have these mini programs that have family planning, education, and awareness programs within those mini programs. And they also have influencer partnerships. Then there are training healthcare providers on the latest assisted reproductive technology techniques and encouraging research and development. So this would bring our healthcare providers up to date on advancements in fertility treatments. And exposure to global best practices would improve care quality and drive local innovations. So before I conclude, I'll like to go through the recommendations that were based on these strategies that China equipped. Firstly, we need comprehensive national policies, backed by government funding, obviously, to make subfertility treatments more accessible. This way, many treatments remain out of reach due to the high costs, especially. Sufficient funding through the government or other private organizations could open doors for many families who are facing these subfertility issues. Another step is in implementing the advanced data systems that I previously mentioned, like the DSS for in vitro fertilization and other information systems. I also propose creating national and private insurances, especially providing subsidies for infertility treatments. This could help reduce the financial barriers and the burdens that the people face when seeking these services. Also, integrating the reproductive healthcare for infertile individuals into the national public systems would represent a strong commitment to reproductive health as a public priority. Then I'd like to move on to the other set of recommendations. Here, as I previously mentioned, the posthumous assisted reproduction. In most specialized areas, we can have this posthumous assisted reproduction, including this post-mortem sperm retrieval and post-mortem oocyte retrieval. And clear policies in this area could offer more guidance and reassurance for the families. Then we can enhance our healthcare infrastructure, especially by establishing fertility centers in suburban areas and rural areas. Because I mainly see fertility centers mainly in the urban areas like Colombo and Kandy, those provinces, but they lack such facilities in rural and suburban areas. then we can have collaborations with Chinese universities and healthcare providers, which can lead to exchange of knowledge and best practices among the two countries. And this can help strengthen our own healthcare framework. Lastly, culturally sensitive programs and community engagement initiatives which can particularly address the male infertility issue. And it's essential. I think it's essential for educating the public and fostering a supportive environment in Sri Lanka. So with this, I'd like to conclude my presentation. So in conclusion, China's journey from the one-child policy to actively supporting fertility treatments hold valuable lessons, which Sri Lanka can learn. This proposal offers a vision for Sri Lanka, a valuable framework that addresses medical and legal gaps while building a community-centered support system. By adopting these insights, we can build a more accessible and a culturally sensitive subfertility treatment framework in Sri Lanka. Here I've given all the references that I've used. With that, I'll conclude my presentation. Thank you for your attention and for the commitment to advancing reproductive healthcare in Sri Lanka.
For another very interesting presentation, and I think maybe one of the additional recommendation, maybe that to China would be, or for us, is to learn that any policy or any program needs to be based on a human rights framework. So if we were to follow some of the very interesting progress that China is making on subfertility care, which is an important under-prioritized area, there's also the importance for us to actually place that within a human rights approach. I think we've heard a lot about that previously, which certainly wasn't the case when they were implementing the one-child policy. So it's very interesting. And I just want to again congratulate and thank all the panelists. Maybe we can give them a round of applause for keeping to time and excellent presentation. We've got 15 minutes, right, for we can take a couple of questions from the audience.
Yes. For the audience, over to you now. You can raise a couple of questions now. So it's very interesting, all 5 presenters. Yes.
So thank you very much for the, your kind of research on the anti-abortion, the whole thing that is coming up in India. Do you think there is a danger of this also moving to countries like Sri Lanka? Because right now, issues are mostly with religious leaders that are based here, and it's still very local. So your presentation was quite scary because it shows funding coming from bigger sources to India. So how much danger are we as a country in this moving to countries in other places in Asia?
I'm not like a very good expert, but definitely what we envisioned, we never thought that this could ever happen in India because these kind of narratives, it's a bit difficult to also enter through saying fetal rights because in India, it's always been driven with a lot of population control lens, and a lot of narratives whenever we talk about reproductive health is from a maternal health lens, so to protect maternal mortality rate. So but what we witnessed was I think especially the growing fascist and fundamentalism has also contributed a lot to enter into to begin enter increase these narratives. And what we saw was it's not just Christian missionaries that are talking about these that are propagating anti-choice narratives, but they are also collaborating with other religious organizations. So as Ragini mentioned, there are Hindu organizations that are also conducting these, and they are also collaborating with big doctors, so in Jain, there is Jawaharlal Nehru University. So it's a very famous university, and there they conducted a conference with doctors, All India Medical Association doctors and Ayurveda doctors, where they try to train them to inculcate Hindu virtues, saying pregnancy culture, Garb Samapan workshop. So like to trace, like to reach out to pregnant women and sort of influence their pregnancies by saying, like you have to follow these Hindu virtues. So like definitely, like these narratives, like also like on the outlook, it seems like, oh, like they are not affecting abortion, but they are, like like you are telling women like how to lead their pregnancy. So there is a lot of interconnection, and like and the person who was leading the abortion, the pro-life movement, so they also said, like that they would want to like collaborate with other religious leaders, and so in that sense, like of course, like it seems like they are growing. And if India has a lot of hold in South Asian regions politics, so then, like there is a lot of threat for even Sri Lanka, where there is already like a lot of anti-choice narratives and movement like happening.
So, just a quick point I would like to add that one of the pro life marches was led by one of the retired judges of the Supreme Court. So, I think what you have to look towards and be careful is that other retired professionals, like in the government, or maybe they are out of the government now, but they carry a lot of legitimacy and they give a lot of credibility to the movement. So, maybe you have to take care of that.
Thank you. A follow-up question on that. Now, India had been. Thank you very much for pointing out about the judge, the retired judge. So now, if you look at the way the pill trials were conducted in South Asia, it was Sri Lanka volunteered to do the birth control pill trials when India rejected, right? So that is again, the Family Planning Association of India was very in early 1960s or late 1960s. So Family Planning Association of India was very specific about, no, our women, we will not give our women for trials. Yeah. So we volunteered Sri Lanka. Okay. So saying that, what is the role? And that time, at that time, it was very much about how the state looked at women's body, and it is very Gandhian kind of stuff, right? When I just heard about the JNU conference, I was like, conference or the workshop, I'm just thinking, what is the state's take on the whole anti-abortion or pro-life stuff?
I mean, they haven't like explicitly said anything, and of course, like like how Ragini mentioned, there are, yeah, they are very right wing, and like they pass like a lot of policies that control like how relationship should be conducted. And there was also, for example, like in one of the states, they released a sorry notice, like that in order to have a live-in relationship, like you have to go to the district magistrate and register your relationship in order to live together. So like in different states, like they do come up with such certain no, you have to register that you are living together. So it's sort of to it's like it's a very anti-Muslim, at the back, like it's a very anti-Muslim thing to like they would say, like that, oh, uh, sorry, I'm just digressing, but the thing is, like that but because of like this narrative, like we have to control like maternal mortality rate, which is why like there is less scope for government to actively say that we that like that we support like anti-abortion movements. So but like it's slowly coming up, uh, because because a like already like because of the right wing movement, women's rights are always under threat, and they are like a lot of narratives are already around this corner. So like it's very in the future, like that this can come up. So yeah.
Thank you. My question is to the Dr. Vimal Ratna about subfertility. Now, it is true that China has one child policy for more than 3-4 decades, and now they are troubling with their fertility. My simple question is that what is the success rate of IVF in China? Now, in Sri Lanka, I know IVF technology success is about 30%. And also you are saying that, I don't know whether China it may be higher than that. But Sri Lanka, the problem is that state sector IVF technology is very slow and very low. Private sector they are doing, but require 3 to 4 million. And insurance companies are not ready to insure women for this particular target because they know that success rate also low and they have to spend a lot of money. Therefore, I don't know how the China is actually in a large scale implementing this IVF technology and also surrogate mother, how it is adopted in surrogate mother. These are the two questions.
So to first answer the first question, the success rates are lower than in Sri Lanka. It's around 20 to 25%. So my point was like they had a one-child policy for around 3 to 4 decades, as you said. Because of that, from that, they have taken the decision to abolish that and then go to the 2-child policy and the 3-child policy, which they have currently have. So from that, they have gained a 20 to 25% success rate. So I think that's somewhat accomplished and somewhat successful from their context. But when compared to Sri Lanka, it's lower than that. So the second question was, I think, how they had that framework in a massive context, right? So first they had, as I have earlier pointed out, they have these insurance schemes specifically for subfertility treatment and infertility treatment. In Sri Lanka, I think they don't have that because I've gone through a few of the insurance companies, how and what their policies and how they reimburse for that. So in that, I didn't find such policies or guidelines. And what they have is they also have, like in Sri Lanka, they have this district-wise and state-wise goals that they have to meet. So with that, with the collectional effect and the collectively, they are reaching towards with that. So how I think the massive scale, how they're doing is each state reaches their own goal, and this brings about a collective, big collective. They reach the collective goal. And about the surrogate mothers, the surrogate mother concept is not that. I have actually, to be honest, I have not studied that particular parts. But with my experience and with my clinical visits in China, I haven't seen that surrogate mother concept in China that much, like in Sri Lanka. In Sri Lanka, it's very popular, and I think they have much resources for that. But in China, they don't have for surrogate mothers specifically. But the other, like that phased development models, with that they have reached so much success.
Thank you very much. I'm really afraid we'll have to come to a close with this session. Again, huge thank you and a round of applause to our panelists. And I know there were some questions that were still unanswered through the fabulous presentation that was made about the anti-choice. I think we all very much focus on the anti-choice, especially now. I think it really is now the time for us to be quite worried about, but worried, but not paralyzed, but really looking at how we are going to be counter that in each of our countries, because it will go everywhere. Sri Lanka, India, Belgium, where I come from and where it's already happened, in Uganda, where it's happened, Ghana, you name it. It is going to be impacting everyone. So please, let's keep fighting and continue the conversation over coffee. And thank you very much for joining us.
Ladies and gentlemen, as we conclude our session, it's time to recognize the exceptional contribution made by our presenters today. We have a certificate to present for all the abstract presenters. Please come and take your certificate. First, I invite Miss Maria Said. Okay. Then Dr. Asanka Patiratna. Dr. Asanka Patiratna. Miss Maria Said. Dr. Saraswati Jagam. Miss Vinita Jayaprakasan, Mr. Hasala Bandara Vimalaratna. Okay. Congratulations and a heartfelt thank you to our presenters for sharing their research and expertise. Your contribution enrich our understanding of these critical issues and inspire meaningful discussions. Thank you all for your dedication and hard work. Thank you to our co-chairs, Ms. Manuel Hurwitz and Dr. Sunetra Pereira for guiding today's session. And thank you all for joining today. We appreciate your participation and contribution to ReproSex 2024. Have a great day and goodbye.